Hi, everyone, and good morning from the North Dakota Department of Health. My name is Molly Howell, and I am the Immunization Director here at the North Dakota Department of Health. Today's town hall, we will be covering COVID-19 and more specifically, reinfections, vaccine effectiveness, and breakthrough illnesses. Towards the end of the town hall, there will be an opportunity for question and answers. And for individuals who were unable to attend the live version of the town hall today, this will be recorded and available on the Department of Health Facebook page and our YouTube page. So I'm just going to go ahead and introduce all three of our speakers before we start. Our first presenter will be Benjamin Schram. He earned a Bachelor of Science degree in Neuroscience and Psychology at the University of Minnesota, and he has a master's in Public Health Epidemiology from New York University College of Global Health. Benjamin has since had the privilege of serving the citizens of North Dakota as an epidemiologist in the Division of Disease Control. He currently serves as the Surveillance and Electronic Reporting System Coordinator in North Dakota, where he ensures consistent and reliable flow of testing, case, and other disease surveillance data from internal and external sources, and he performs regular data analysis. Benjamin is part of the team that has developed the state's COVID-19 dashboard and public data set. Our second speaker is Dr. Paul Carson. He's an infectious disease physician and professor of practice in the NDSU Department of Public Health. He has over 25 years of experience in various clinical capacities and currently works with the North Dakota Department of Health on many projects, including healthcare-associated infections, antimicrobial stewardship, and vaccine education. And then our last speaker is Jenny Galbraith. She has a Bachelor of Science degree in biology from the University of Mary. She has worked as an epidemiologist with the North Dakota Department of Health for the past 5 years, and most recently serves as the COVID vaccine manager, ensuring all North Dakotans have access to and are educated regarding COVID-19 vaccine. None of our speakers today accept funding from pharmaceutical companies or vaccine manufacturers. And so now I will turn it over to Benjamin Schram to discuss where we are in North Dakota in terms of COVID-19 cases and reinfections.
Thank you, Molly. I'd like to begin today by sharing a brief overview of the current state of COVID-19 in North Dakota. Today we have 2,006 active positive cases. This is the largest since the end of our previous peak in January. As you can see here, a comparison between 2020 and 2021, we can see that there is actually a rather steep slope compared to that of last fall, and we do have approximately even active cases at this time of year. Looking at our new cases, 363 individuals tested positive yesterday out of a total of 7,118 tests with a positivity rate of 5.51%. While individual days can have fairly wide variance in positivity, we often use a rolling average to better view changes over time. Here you can see our current 14-day rolling average case count is 196 cases per day. This is the highest it has been since mid-January. And we can again see that we are pretty close to where we were last year, just a little bit higher. While our cases are fairly similar to those from last year, we are seeing significantly less testing compared to last year. With less testing, there is a possibility that we are having more cases go undetected. And here we can see the current 14-day positivity rate, which is 5.9%. This is a fair amount higher than it was last year at the same time, and it is up from only 1.05% in early July. We do see this is fairly similar to the lead up to our peak last fall, and we have not had a rolling average positivity this high since mid-December of 2020. Finally, I'd like to show active hospitalizations. We do expect are slightly reduced due to the higher rates of vaccination in higher age groups. However, we do still see that hospitalizations are roughly even with last year's trajectory. One of the things that we have this year that was not present last year are the SARS-CoV-2 variants. Since we began monitoring for variants last year, we've seen 1,150 alpha, 4 beta, 526 delta, and 42 gamma variants. In recent weeks, however, we've seen nearly exclusively delta variant in circulation. It's important to note here that we're unable to test all positive cases in the state, so these numbers do not match our total case counts. A portion of the test samples that were detected through PCR can be submitted for genetic sequencing, and the variants are then detected by comparing to the genetic sequence of a known strain of the virus. And we can see how the trends in variants have changed over time. As we can see, back in November, we mostly had variants that were not of concern, which then led into epsilon and alpha variants. And then in the last 6 weeks, we've had nearly exclusively delta variant. For those who are sick with delta variant, they actually pass it on to approximately 6 to 8 other people on average. So this is a much higher infection rate than the virus that we had here circulating last year. In the last 2 weeks, in the last 2 weeks, since Delta began to spread, we've had 526 Delta variant cases spread throughout the entire state. 5 of those have died and 47 were hospitalized. Out of all of those, only 21 of those cases were vaccinated, and only 1 of those was hospitalized, and none have died. Before we go on to discussing vaccine breakthrough infections, I would like to share some information about reinfections. Researchers are still studying and learning more about the immunity due to a natural COVID infection. However, the current understanding is that there's a period of around 90 or more days of immunity in most people. The level of immunity due to a natural infection varies and is weakened over time, and is particularly weak in defending against some variants of concern. Comparing this with vaccination, laboratory evidence is showing persistent and improved defenses even against these known variants of concern. In a recently published MMWR, which is a Morbidity and Mortality Weekly Report published by the CDC, researchers found that being unvaccinated was associated with a 2.34 times odds of reinfection compared to those who were fully vaccinated. This shows that even in those people who were previously infected, vaccination offers a significant level of protection. Another study in the UK found that the odds of reinfection with Delta variant was 1.46 times that of reinfection with the Alpha variant. This shows evidence that natural immunity for Delta is lower compared to even another strain of variant of concern. With Delta being the primary variant in circulation in North Dakota and the surrounding region, this shows the need for vaccination to enhance the immunity even for those who were previously infected. On June 27th, 2021, the Council of State and Territorial Epidemiologists, or the CSTE, approved a new COVID-19 reinfection case definition, which is based on that 90-day expected natural immunity. We have since included these cases in the daily case updates, which are reported on our website. Here you can see our new dashboard. Our main page now has reinfections since June 27th, published right underneath the cumulative label on the far right top. In addition to this, we would like to also share with you some information about those reinfections that occurred before June 27th. Basically between March 20th and June 26th, for those that would have met this new case definition, A total of 947 cases were identified. Of those 947 reinfections before June 27th, 586 were fully investigated by our contact tracing and case investigation team as a potential reinfection. Of those 586 possible reinfections, 38 were hospitalized and 10 died. The remaining historical reinfections meeting the new national reinfection case definition were not identified as potential reinfections at the time, and so we did not have interviews and do not have hospitalization, symptom history, or death information gathered. We are continuing to work on this information and hope to provide it in the future. In these charts, you can see both the month of original infection on the left and the month of reinfection on the right. You can see we do have a peak in reinfections approximately 3 to 4 months following our November peak from last fall, which is likely reflective of some of those individuals being reinfected just after that 90-day period. Of those 946 reinfections, here we can see how they were spread throughout the counties in North Dakota. As we would expect due to population size, Burleigh and Cass County led the state, but we did have reinfections throughout the entire state. We can also see here the age groups in which those reinfections occurred. The age group here with most reinfections is the 20 to 29-year-old age group with 20.1% of those reinfections, followed by the 30 to 39-year-old group with 15.2%. As Jenny will likely discuss later, vaccination has been effective in moving the average age of infections back to the 50s compared to an average in the 30s for those who are unvaccinated, even in those who were previously infected by COVID. Of those 947 reinfections, we can also here see the breakdown of gender and age group. We do see that there are more reinfections in females here than males, and we can also see those trends in the 20 to 29 and 30 to 39 age groups having the largest number of reinfections. I hope this information helps you all in understanding the difference between immunity from a natural infection compared to getting vaccinated. Not only is relying on being infected due to being infected to build immunity less effective, it's also dangerous due to the potential for serious illness and long-term side effects like reduced lung capacity or even loss of taste. We have vaccines that have been proven to be safe and effective, and I encourage you to talk to your doctor if you do still have any concerns, and they will be able to give you an appropriate assessment of the vaccine and your health. Thank you.
All right, and so now we will turn it over to Dr. Carson to kind of talk about vaccines and vaccine effectiveness.
Good morning, everyone. Thanks, Molly. So my portion of the presentation this morning is to go over some of what we might expect with the surge in cases related to Delta, the Delta variant, and what we might expect with the current vaccines. So I do get a lot of questions from people now about how much or will the current vaccines in use protect me against the Delta variant. We actually have quite a bit of data accumulated on this now from a number of different countries and a number of different settings. I'm going to walk through some of that to give you, I think, hopefully a broad picture of where this stands. So this is kind of a busy table, but I'll go through it sort of in steps here. So we have data that's come from a number of different countries: the United Kingdom, Canada, Israel, Qatar. More recent non-peer-reviewed study that was put out online from the Mayo Clinic, and then a few others here in the US that I'll get to in a second. So first, about symptomatic infection. So any kind of symptomatic disease or illness, which could include, sort of mild cold-like symptoms or flu-like symptoms, and even the more severe. In the pre-Delta, the vaccine efficacy we saw in the clinical trials was as high as 94 to 95%. When we actually look at that in real world data, what we call vaccine efficacy, it usually drops a little bit. And what we saw was pretty good protection against most any symptomatic infection. 93% in the UK, 87% in Canada, 93% in Israel, 91% in Qatar. And then in the Mayo Clinic, 87% with the Pfizer vaccine, 92% with the Moderna vaccine. That was pre-Delta. What's happened since Delta? There has been some erosion or chipping away at that efficacy. Still, some big studies out of other countries, the UK and Canada, showing it to be in the 80% range, something that we would still consider a very good vaccine. But other places, particularly Israel, showing much lower rates now of efficacy. This is where we hear about breakthrough infections. And again, we're just talking about symptomatic infection, which can be, colds and flu-like illnesses. Down as low as 41% in Israel, 54% in Qatar, Mayo Clinic showing 42% with the Pfizer vaccine, and a little bit better with the Moderna vaccine. Not clear if this is going to hold up in other studies, but 76% there. So there was some chipping away at the efficacy of the vaccine to protect against symptoms of any type of infection. But what we care most about is severe disease. So when we focus on severe disease, which is usually defined as needing oxygen or being hospitalized or dying, we see that the vaccines in almost all the settings still hold up quite well. So out of the UK, 96%, Canada, 95% protection, Israel, where we saw the most erosion in efficacy against symptomatic infections, still 91%, Qatar 90%, a little lower with this Mayo Clinic study. Again, that has not been peer reviewed and published yet, just sort of put out online. 75% against severe disease with the Pfizer, 81% with Moderna. Couple more from the US in different settings. In one large study here in US healthcare workers in 8 different locations, symptomatic infection went from 91% protection pre-Delta to 66%. So that's kind of getting closer to what Israel was seeing. 66% protection in the Delta phase. New York, symptomatic infection went from 92% pre-Delta down to 79%. Hospitalization still strong, 95% protection. I think one of the things that probably has us, concerned, the population that has us concerned the most would be nursing home residents. Here, protection even pre-Delta was a bit lower than what we would see with other populations, not unexpectedly. The elderly, people who have a number of chronic medical conditions, are less likely to mount a robust immune response. And so even in the pre-Delta, their protection was a little less than other populations, down to 74%. And that dropped in this study down to 53%. Now this is infection, any infection, actually asymptomatic or symptomatic, not severe disease. They didn't talk about how well it protected the nursing home residents against severe disease. And I think we need to see that kind of data. And then in this 18 different US academic hospitals, hospitalization, so severe disease, still holding pretty good at 84%. So although there's been some erosion of protection against the sort of cold and flu-like illness, it's still holding out very well in nearly all settings and countries that have looked at this against what we care most about, which is severe disease. Now, why is this declining? We don't know for sure, but we're seeing some patterns here that probably explain some of this. It does appear that if you are older, you may be more likely to break through. According to the CDC data, of the breakthrough infections that lead to hospitalization or death, almost 75% of those are in people over the age of 65. The other risk factor may be time from the original vaccine. We know that antibody levels can diminish or slowly fade over time, and now that we're getting out 8 months or more from the original groups of people that were vaccinated, some of that protection may be declining. And Delta itself may have some ability to make it harder for antibodies that were derived from the original strain of the virus and the spike protein that was designed after. The new Delta variant might be making it a little bit difficult for those antibodies to knock it out. I want to give, no pun intended here, a little inoculation against a misunderstanding, which is sometimes even used as misinformation. As we vaccinate more and more people, we will increasingly see a headline that looks like this. It's not quite like this in the US because we still are lagging in getting our vaccine numbers up anywhere close to what Israel has. But as we vaccinate more people, you will see something like this. A headline here says, Israel says the Delta variant is infecting vaccinated people, representing as many as 50% of new cases. Some will even say over 50% of new cases of infection are in the vaccinated. Well, what I want to kind of caution you against when you look at that is partially true, but it's wrong to conclude that that means the vaccines are failing. So this raises a question in people's minds, and I see this out on social media a lot. I'm hearing that more than half or more than half of the people getting COVID-19 are vaccinated. Looks like the vaccines aren't working. This is commonly known in epidemiology as the base rate fallacy. And what you need to actually look at is the attack rates in the two groups. So to kind of visualize that, this is actually not too far off from what Israel's adult population is. They're pushing 90% of their population being vaccinated and about 10% unvaccinated, particularly in the elderly. So if you look at getting COVID in these two groups, you may have like 6 people in the vaccinated group getting COVID and 5 people in the unvaccinated group, and you can legitimately say more people who got COVID were vaccinated. But you can obviously see that the denominator or the pool that's appearing from are vastly different. So the attack rate here is 50% in the unvaccinated, and it's only 7% in the vaccinated group. You are much better off being in that vaccinated group than in the unvaccinated group. So just be a little aware, because it'll be coming as we get more and more people vaccinated in the US, of the misunderstanding of what we call the base rate fallacy. More to the point, we want to look at what we call incidence of these diseases, particularly severe disease, which is what we care about. We care, if we turn COVID into something that causes colds or mild flu, that's okay. If we can keep people out of the hospital, if we can keep people from getting severe complications, and if we can keep them from dying. Israel shows this data the right way, and I think we're going to see in just a second from Jenny that North Dakota is going to try and do this as well. What we want to see is incidence in the different groups. What does severe disease look like in the unvaccinated versus the partially vaccinated versus the fully vaccinated? And here Israel reports this in the most at-risk group, people over the age of 60. And you can see that people who are fully vaccinated are creeping up there are some cases of severe disease that are creeping up, but still vastly lower than those who are not vaccinated. That's a 9-fold difference. You are far, far better off being in that vaccinated group if you're looking to try and avoid severe illness. This is now being seen and data is being reported the way we would like to see this. That gives you the best sort of understanding of it. This was just published in that Morbidity and Mortality Weekly Report, the CDC's journal, from a study of the hospitalization rates, here again, severe illness in LA County. And you can see this is the vaccinated, the fully vaccinated, the dark blue line. And yep, there's a teeny bump up in cases of people being hospitalized amongst the vaccinated, but still quite low. Whereas those who are unvaccinated, the black line is just going up and up and up. Here, it's a 29-fold difference. And the kind of headline from that article was, unvaccinated had 5 times more COVID infections than the fully vaccinated and 29 times more hospitalizations than the fully vaccinated. Far, far better off being in that vaccinated group. So then the other question comes up is, what about booster shots? So we know that people who are immunocompromised, who have conditions that make them less able to mount a good immune response, are at greater risk for not responding to the vaccine. So when you compare antibodies made after vaccination in healthy healthcare workers, 98% will make good antibodies compared to people with HIV infection. Depends on their stage of HIV, but actually not bad. Autoimmune diseases down to 84%, solid tumors or cancers 82%, but the big risk groups are people with hematologic malignancies, that's like lymphomas and leukemias, down to 55%, and people who've had organ transplants down to 37%. So these folks are at very high risk of not having a really good response to the vaccine and therefore being still unprotected to to COVID that's circulating in the community. And because of that, the Advisory Committee on Immunization Practice, the CDC's guidance committee, recommended that for people with moderately and severely immunocompromised states should be eligible for a booster dose of the vaccines. That includes active treatment for solid tumors and hematologic malignancies, receipt of a solid organ transplant, that's like kidney transplant, liver transplant, heart transplant, and still taking immunosuppressive therapy. People who are on certain types of drugs for during stem cell transplants, that's like a type of bone marrow transplant, and are still within 2 years of their transplant and taking immunosuppressive therapy. Moderate or severe primary immunodeficiency diseases, these are severe immunodeficiency diseases. Advanced or untreated HIV infection, and people who are on high-dose steroids and some other drugs that suppress the immune system. These folks are eligible to get a booster shot of the vaccine and should seek that out. Kind of looking at this again out of Israel, which I think is a few months ahead of us and things, much more vaccinated, but big Delta surge there. You can see here when you look at severe cases again, there's a big difference by age group. So the red here is how many cases there are. This isn't adjusted for the who's in that group. How many are on? Oh, I'm sorry. This one is adjusted. This is per 100,000 people in each of these groups. So this is adjusted for the population in each of the groups. Unvaccinated, high rates of severe disease, and it goes up if you're older. I mean, if you're over the age of 50 or 60 years old and still unvaccinated, you're really taking a great risk. And you can see though that the vaccinated, the green here, also have a bump up in severe cases, especially if you're in your 80s or 90s. So this is kind of why we still are thinking about needing to be careful, looking at needing booster doses, particularly with our elderly, even if they may be vaccinated. You may have seen in the news announcements from the White House that the Biden administration announced that booster doses would be available for Americans 8 months after vaccination, starting around September 20th. I think a lot of people in public health thought that was maybe jumping the gun a bit. We usually like to see the CDC's Advisory Committee on Immunization Practice issue guidelines. I think they will. We were hoping that they were going to do that with their meeting next week, but it doesn't appear that that's on the agenda. And so we're probably going to be waiting for formal guidance on this. I think it's probably safe to say with the Biden administration announcing this that some form of boosters are going to be more widely available by late September. And to kind of give a little bit of data on that, there are several studies now that are ongoing looking at what boosters do for protection. Both Moderna and Pfizer have submitted preliminary data from what we call phase 2 studies on a booster dose and what it does in the test tube and what it does for protection. There are no Delta specific boosters currently being studied right now. There were some other variant specific boosters. I think it was the South Africa variant or that was being looked at, but none for Delta specific. But we got, again, out of Israel, a hint of what may be to come. Israel had started giving booster doses to everyone over the age of 60, and I think they've actually maybe even lowered that to everyone over the age of 50, I believe. They started doing that around late July, what we see is that unvaccinated continue to go up in their Delta surge, but this is again people over 60. The elderly vaccinated, after population-wide putting out a lot of booster doses, has started to plateau and decline. So that booster does seem to be having that booster campaign seems to be having an effect in Israel. We also know from test tube studies that you really get very high antibody levels about 7 days and 1 month after a third dose of the booster against all the variants, including Delta. Very, very good antibody levels. So there's reason to think that a booster dose will help quite a bit against Delta. If I had to speculate, and I don't know what will happen with this, but if I had to speculate about what the ACIP will suggest for guidance on boosters. I suspect they will take age into account and probably be recommending it for some portion of the elderly population. Probably time from last vaccine, taking into account that, you know, if you were vaccinated 2 months ago, you still probably have very good levels and might not need a booster. They may take into account high-risk work settings like healthcare workers, and they may take into account other comorbid conditions, maybe not so severe of immunosuppression, but maybe things that have more modest effects on your immune system like diabetes, etc. So as we've kind of said, you know, I think it's true that we are all facing, if you have not have been vaccinated, or if you're not, if you've not been infected before, and we heard you know, Brian talk a little bit about reinfection, but I think this is so contagious that it's likened to chickenpox. All of us, you know, before chickenpox vaccine was available, were infected with chickenpox. Usually by the time we were around 4 or 5 years old. I think it's pretty safe to say that most everyone, if they are not vaccinated and have not already had it, are probably going to get this in the next several months or early into next year. So you're really making a choice of take the vaccine versus take the virus. And you know, the math is just, we've gone over this before, the math is overwhelmingly in favor of the benefits of taking the vaccine as opposed to taking your risks with the virus. So we want to try and get ahead of the curve with Delta. It's bearing down on us, as we've already heard. If people aren't vaccinated and contemplating it, I would urge them to do it sooner rather than later. And if you aren't sure where to go to get a vaccine, you can look at vaccines.gov and it'll help you find a vaccine near us. And then the last thing I would want to put a plug in for the monoclonal antibodies. This is the same treatment that President Trump received when he became infected with SARS-CoV-2. These are antibodies that are developed and can be given as a single infusion, and they actually are pretty efficacious. If you have COVID and you meet one of the criteria, which is older, diabetes, obesity, other different risk factors for progressing to severe disease, vaccinated or not, if you get COVID and you have one of those risk factors, you are eligible to receive these infusion of these monoclonal antibodies. They actually have been shown to cut the risk of hospitalization and death by about 70%. And so if you're if you do get diagnosed with COVID, seek this out with your healthcare provider if you're in one of those high-risk categories for progressing to severe disease. So I will stop sharing there.
All right, thank you, Dr. Carson. And that's a good plug too. If you have respiratory symptoms or symptoms of COVID, don't wait to get tested, because you need to get tested and we need to know if you have COVID in order to prescribe monoclonal antibodies. So testing continues to be important as well, and early identification that you have COVID-19. All right, I am going to turn it over to Jenny Galbraith to talk about breakthrough infections.
Yeah, thanks everyone. So like Molly said, I am here today to talk about breakthrough infections. But before I get into kind of the state of breakthrough in North Dakota, I'm just going to do a quick overview of kind of where we are at for vaccination rates in North Dakota, just to level set everyone. So this data is taken off of the CDC data tracker, and that's on the CDC's website. It includes data from providers that receive vaccine directly through North Dakota, but also would receive vaccine through federal channels as well, like our Air Force bases, some of our federally qualified health centers, those kind of individuals. So when we look, and we'll just use 18 and older as kind of an example here, when we look at North Dakotans 18 and older who have completed their vaccination series or completed their primary vaccination series, we're sitting at just over 51% of individuals that are fully vaccinated. As you can see, that is quite a bit lower than the US national average. And again, as you look at this map, basically the darker the color is, the higher the vaccination rate. So as you can see, our western side of the state really does have significantly lower vaccination rates. Our counties do vary quite a bit, with Nelson County being our highest at 71.2%, and Slope County out in the west being our lowest at 11%, or just over 11%. So before we dive into kind of our updates for the dashboard, first important thing is we need to make sure everyone is aware of what a breakthrough case is. So a breakthrough case is an individual that tests positive for COVID-19 after they are fully vaccinated. And for public health purposes, fully vaccinated is someone who's completed a primary vaccination series. So that would be 2 doses of the Pfizer or Moderna vaccine or 1 dose of the Janssen vaccine, and then 2 weeks after that, basically to let the body create kind of as robust of an immune response as you can get directly after vaccination. So these individuals that are breakthrough cases have all met that fully vaccinated criteria, then subsequently tested positive for COVID-19 days, weeks, or months after that vaccination. So we do identify or we do assess vaccination status on all of the individuals who test positive for COVID-19 during the contact tracing process in North Dakota. Couple clarifying points. These are individuals who test positive on PCR or antigen, and wastewater testing data is not used to do any sort of estimating of breakthrough numbers. We also hear a lot of questions about do we investigate cases that are have a really high CT value? And yes, we do. So the little bit of a misinformation or miscommunication that happened from CDC is that whole genome sequencing can only be performed on those with a CT value of 28 or lower. But just because someone has a higher CT value doesn't mean that we change their status as a breakthrough case. Another quick point of clarification is you may see that CDC collects data on hospitalized individuals or individuals who have died that meet that breakthrough case definition, but here in North Dakota, we do continue to assess breakthrough on every case, regardless of hospitalization status, death status. Really, anyone who tests positive would be able to identify as a breakthrough case if they are so. So Ben kind of already alluded to this, but we did make a number of updates to our dashboard here at the Department of Health. And one of those major updates is including now our breakthrough cases publicly. So I'll go over here individually each component of the dashboard and give you a little overview, but I did want to draw everyone's attention to that quick statement up at the top. So since COVID-19 vaccines were available on December 14th in North Dakota, 1 in 228 fully vaccinated people have tested positive for COVID-19. And you can compare that to 1 in 16 unvaccinated people. So really, as we dive through, you'll see, but even just from the beginning, you can see that these vaccines are effective and have really decreased the risk of individuals testing positive for COVID, and especially decreased the risk for hospitalizations and death. First, we're going to look at hospitalizations. So what we've done on our dashboard is given you a timeline of kind of everywhere or however long vaccines have been available in North Dakota. So again, December 14th through now, and really given you by day or by week how many cases, just a total number of cases vaccinated versus unvaccinated. So like Dr. Carson said, it's going to be really important that we look at this with an incidence, so individuals per 100,000 that have been hospitalized. But we also have included just the percent of individuals who are fully vaccinated that have been hospitalized. And as you can see, that's 0.0333%. So there's a really small percentage of our population that are up to date and fully vaccinated that have tested positive and then subsequently been hospitalized from COVID-19. I did want to draw out or point to everyone's attention that this does match what hospitals are reporting out on their Facebook pages or the media. So on the left, you can see a graphic from Altru up in Grand Forks, and this does say that 91% of their hospitalized patients at Altru were unvaccinated, and that's February to August of this year. And Sanford has a similar graphic where they break down their hospitalized ICU and ventilators by their vaccination status. And we also have posted this information here recently, actually yesterday, at the Department of Health Facebook page, where you can see that as of yesterday, we had 53 active hospitalizations, and out of that, 51 of those were not fully vaccinated in North Dakota, meaning only 2 of these individuals would be considered breakthrough cases. So like Dr. Carson said, it's really important that we don't just look at just numbers, and we really take into account kind of that background population and really look at individuals kind of on an incidence or rate level. So This is, as you can see, the breakdown of by ages for hospitalizations and then by vaccine status. So as you can see, no surprise, Dr. Carson has kind of already alluded to this, that a majority of our breakthrough hospitalizations do come through our older population. So really that 70 plus group. But even with that slightly more higher risk of hospitalizations and breakthroughs in that older population, you can see that there is a significant difference in your risk when you're not vaccinated. So again, if you're older and not vaccinated, you really are taking a relatively large risk of hospitalizations from COVID. And here on our dashboard, we do also break down our average age of hospitalization for our COVID positive individuals. So as you can see, if you are vaccinated and are a breakthrough case, our average age is about 73, so that older population. As Delta has kind of come into North Dakota and our hospitalizations have changed, we can see that our hospitalization for those who are not fully vaccinated has dropped down and is actually at 59 years of age. So again, this just goes to show that we know that vaccines may not be as effective again in those that are older, and really that hospitalization years of age shows that vaccines are relatively good at protecting against hospitalizations, especially for that younger population. So then we're going to just look at kind of our total number of cases. So as of right now in North Dakota, we have just shy of 1,400 breakthrough cases in North Dakota. Again, though, when you compare this to the total number of individuals that are fully vaccinated, less than 0.5% of those individuals have tested positive for COVID-19. Again, as you can see, this kind of shows the spread over the entire time vaccine has been available in North Dakota. And we do know that, as Delta has been introduced into North Dakota, our breakthrough cases have started to increase slightly. We also break down kind of by the timeline of vaccines in North Dakota, the incidence of vaccinated versus unvaccinated individuals testing positive for COVID. Again, as you can see, there is a significant increase in the rate that individuals who are unvaccinated test positive for COVID. And again, we break it down by age. This one's might not be quite as substantial as the age differences for the breakthrough cases. But as you can see, there is still a very large difference of your rate of getting COVID if you're vaccinated versus you're not vaccinated in North Dakota. And then we've broken it down by age. As you can see, like Ben already talked about, our average age of infection for breakthrough is significantly higher than our average age of a breakthrough case that's not fully vaccinated. And what we know is that this vaccine is effective and it does look to be working relatively well in that younger population. So then I want to touch briefly on deaths. Deaths are kind of a tricky thing to report. We do know that there's a lag sometimes when someone dies to when they're reported as having died from COVID. So right now we have 19 breakthrough deaths in North Dakota, and that roughly ends up to being about 0.00602% of fully vaccinated individuals have died from COVID. We don't provide a kind of daily count or weekly count as we do in the other ones. It's just not as effective. We know that breakthrough cases or deaths are just kind of a tricky timeline to report on. But we do, as always, provide the age breakdown of those individuals who have died from COVID as compared to those who have died not vaccinated from COVID. As you can see, again, a majority of our deaths, no surprise, are in individuals who are older and may tend to have more chronic conditions. But again, there is a significant difference in your rate of dying if you're not fully vaccinated versus if you are fully vaccinated. So again, as Dr. Carson said, if you're an older individual, taking kind of your own risk into your own hands if you're not fully vaccinated at this point. And again, our average age of deaths in those who are breakthrough cases is higher than those who are not fully vaccinated. I did want to touch briefly just a little bit about hearing breakthrough case data in the news. And Dr. Carson has kind of already talked about this, but I'm going to give a few different examples than he has. So breakthrough cases are being reported more and more frequently, but it's really important that we look at this data and really know what's being reported on and kind of read everything with a critical eye. So Dr. Carson has already touched on base rate fallacy or base rate bias, but I'm going to go over it again just to make sure everyone was able to hear that and able to understand. So when we talk about a base rate, that's the probability of some event, that could be a disease, a symptom, a characteristic, something else happening. So for example, if you would hear 6 in 10 adults in the United States have a chronic disease, or the rate of new cases of cancer is 442.4 per 100,000 men and women per year. So when we have base rate bias, that happens when you make judgments on that data and ignore that background probability of that event already happening. So if you look on the right, for example, if you have a town or a population of 100 people and all 100% of those people are vaccinated, and you have one case of COVID, of course, 100% of your infections are in positive or on breakthrough individuals or vaccinated individuals. There's no other choice. There's nothing else that could happen in this case. So to demonstrate this a little bit more clearly, I'm also going to use the Israel definition or the Israel case. So the Director General of the Health Ministry of Israel was asked during a radio interview how many of their new COVID cases had been vaccinated. And at that time, he reported that they were looking at a rate about 40 to 50% of their new positive cases were in their vaccinated population. So at that time, about 85% of Israeli adults were considered fully vaccinated. So if you simplify that down a little bit and look at and assume that the total population is 100 people and use that 85% vaccinated rate, you then have 4 COVID cases, 2 in the vaccinated population and 2 in the unvaccinated population. A lot of the time you would hear that then reported in the media that 50% of cases were among the vaccinated group. But like Dr. Carson already talked about, that's not really the full picture. That's not really the full story. What we really need to look at is the infection rate among those 2 populations. So if you take those 2 individuals out of the 85 that are vaccinated, you can see that there's about a 2% infection rate among the vaccinated. And then when you take those 2 individuals in the unvaccinated group, that's about a 13% infection rate among the unvaccinated. And as this kind of demonstrates, even though 50% of cases, just numbers wise, might be in the vaccinated group, really your chances are significantly lower of contracting COVID if you're in that vaccinated group with that just higher population overall. Another way we can look at this is if we look at a Kentucky nursing home study. So there was a skilled nursing facility with 83 residents and 116 healthcare workers, and they were all offered COVID vaccine through various COVID vaccine campaigns. So the rate that they had kind of been stable at for a while was about a 90.4% fully vaccinated rate for residents and a 52.6% vaccinated rate for staff. So on March 1st, and just again to make sure I'm level setting everything, this was before Delta variant really hit in the United States. So on March 1st, an unvaccinated symptomatic staff member came to the facility. And then once they identified that outbreak, the facility conducted daily testing of individuals, both symptomatic and asymptomatic, to really see what was happening after vaccine and really to get a kind of good real world vaccine efficacy in this group. So as you have our index case and we have our vaccinated versus unvaccinated residents. So just looking at these colors, it looks scary that more individuals tested positive in the vaccinated group. But again, like Dr. Carson said, you really need to look at the attack rates of what's happening here. So if you look to the left, the attack rate amongst the unvaccinated residents for symptomatic disease was 62.5%. Comparing that to the vaccinated residents, their symptomatic attack rate was only 8.5%. That is a very large difference, even amongst this population that we know the vaccine might not be as effective in. And even the death rate is significantly higher in the unvaccinated population, even with this group that we consider kind of our most vulnerable, our most sick. So in the unvaccinated group, the death rate was 25% versus our vaccinated group, which is 1.4%. So it looks kind of similar also when we look among staff, even with that 50-50 vaccination rate. So the attack rate for just symptomatic disease for the unvaccinated staff was 27.8% compared to 3.6% among the staff that were vaccinated. And no individuals died in the staff. So again, this just really demonstrates that rather than looking at the number of cases overall and making judgments on that, you really need to look at the attack rate and the actual population that already existed that was vaccinated. And last, I'm just going to talk about, this one has been in the news quite a bit recently, of an outbreak in Massachusetts, and this was Barnstable County, Massachusetts. And a lot of the media is reporting that it's 3/4 of people infected were breakthrough cases, or the actual percent was 74% of cases. But again, this 74% statement lacks context. We know that in Massachusetts, this vaccination rate was around 70%, but we really don't know among every person who was in the county during that outbreak. This was during a large public gathering that brought in individuals from other states as well, how many were vaccinated and how many were not. Without this information, we really can't make any conclusions, any jumps on how effective the vaccine is. So again, if we had this information, we would calculate out the percent of people infected in the vaccinated versus the unvaccinated group. But really, again, more importantly, to see how effective our vaccine is doing against severe disease, we could then calculate out that same percentage for hospitalizations and deaths. It is important when you're seeing reports in the media that you look at the actual study, because this study actually notes its own limitations in their conclusions, that the data from this report is insufficient to draw conclusions about the effectiveness of COVID-19 vaccines against SARS-CoV-2. So again, it's really important that rather than stopping at that news article and just reading that headline, that you do a little bit more deep diving and actually look to see what the rate of infection actually is in our two groups. And then lastly, I just wanted to kind of wrap up our key takeaways here. We know vaccines are not 100% effective. We will have breakthrough cases. It's inevitable, and no vaccine is perfect. However, they still significantly reduce the risk of COVID-19 disease, hospitalizations, and death. We also know that breakthrough cases are more common in older, potentially chronically ill North Dakotans. And with that information, we really need to make the decision that we're going to get vaccinated to protect those most at risk in our community and really surround those that are at risk with individuals that are doing everything they can to protect them. Thank you. That's all I have.
All right. Well, thank you to our three speakers who joined us today. We have been getting a lot of questions, and I've been trying to answer some of them in the chat here, but some of them I want to ask more specifically. A lot of questions about whole genome sequencing and Delta, and why are we not doing whole genome sequencing on all of the positive tests that we receive. And so I did answer that in the chat, but basically we don't receive specimens on 100% of our positive cases to do whole genome sequencing on. If somebody receives an antigen test, we cannot do whole genome sequencing on antigen tests, only specimens from the PCR testing. And also the Department of Health lab does not do 100% of the PCR testing in the state. But how we do know the prevalence of Delta, or how much Delta is in the state, is you can kind of extrapolate that based on the percent of our whole genome sequencing that is Delta. And so that's kind of how we determine how widespread Delta is in the state. And for the past few weeks, it's been all Delta in the state of North Dakota. And so if you have tested positive for COVID-19 in the past few weeks, you likely have the Delta variant. But I did want to ask this question. So Dr. Carson, if somebody had COVID-19 previously, would you recommend vaccination, and why? And especially, some people are having their antibody levels checked or getting titers done. If they still show that they have some titers to COVID after having been infected, should they still be vaccinated?
Yeah, I think that's a real fair question, and I think I don't think we should be sort of dividing the world into the vaccinated and the unvaccinated. There's a third bucket, and that's previously infected. And And in the past, we've seen that most of the time natural infection tends to induce better immunity than vaccines do. There's been some evidence that that's not the case with COVID, although I think it still needs to be determined. So there's some data that shows in the test tube, people who are vaccinated make about 10-fold higher antibody levels than people who had prior infection. You can also show in the test tube that people who are vaccinated make better antibodies, meaning they can neutralize the virus better than those with previous infections against the variants. So there, you can show that vaccinated people's antibody response neutralizes Delta, for example, better than people with a prior infection. We have the data from that was published and mentioned by Benjamin that showed about a 50% lower likelihood of reinfection in people who have been vaccinated compared to people who had been previously infected. Now, that was just sort of challenged, I think it was just today or yesterday, a study out of Israel, non-peer-reviewed, not published yet, needs a lot of scrutiny, that suggested maybe the opposite, that reinfection might be higher with vaccination than with prior infection. What I suspect, though, I mean, what we really need to pay attention to here is hospitalizations and death. That's what matters, and we just don't have that data yet. And so that's yet to come. What we do know is that if you have not had prior infection, and if you aren't vaccinated, to get immunity, taking your chance with the virus is a much worse proposition than the vaccine. You will take your chances with long COVID. You will take your chances with hospitalization. You'll take your chances with death. Now, that said, I think we need to see what the hospitalization rates and deaths and so are after prior infection. We also know that people who've had previous infection, even with one additional dose, even with one dose of the vaccine, mount to an outstanding antibody response. People who get both doses of the vaccine have the greatest antibody response of all, most neutralizing antibodies of all. So if people are very, very nervous or hesitant about the vaccine, I encourage them to take at least one dose. You will be amongst sort of the golden elite of antibody levels. And there's no identified downside to it. There hasn't been any noted more serious adverse effects from people who had it previously and get vaccinated. So I've encouraged people that I know and family members that I know that have had it to get vaccinated, at least with one dose. And if you want to be able to have the full vaccine card for whatever that may mean in the future, you should probably complete the series.
All right, thank you, Dr. Carson. Another question that we have is, should you go in and have your antibody levels checked before you get an additional dose or a booster dose? Jenny, did you want to take that one?
Yeah, of course. So right now, the Advisory Committee on Immunization Practices does not recommend that anyone go and get their antibodies tested prior to vaccination. Really, right now, there's a lot of misinterpretation of those results when they are reported. So the general recommendation is, regardless of your antibody status, you should be still getting vaccinated.
All right. Other questions that we received here, and Jenny or Dr. Carson, you can maybe answer this. Do we have a time frame for when COVID-19 vaccine will be available for 5 to 12-year-olds?
Go ahead, Jenny, if you know.
Not a great time frame yet. What I can say is that Pfizer has submitted some data, and they're still working on kind of through the VRBPAC channels, through ACIP, what that timeframe is going to look like. It likely won't happen until, and Molly, feel free to correct me if you've heard anything new, later on this year or maybe earlier next year, depending on how everything works together.
All right. Ben, there's a lot of questions about our hospitalized cases and whether or not they have underlying health conditions or are healthy. I was able to answer some of those questions. In the past week, 38 out of our 141 hospitalizations, those 38 individuals did not have any underlying health conditions. But a lot of, did you want to add to that at all, Ben, and some suggestions that that information would be available on our website?
I would say we definitely can consider adding that to our website. I'll have to bring that to our team to investigate that potential.
And then Ben, in talking about the data on our website, a lot of questions about when it gets updated and how often. Can you talk about how often the Department of Health COVID-19 dashboard is updated?
Yeah, our dashboard is updated every day at about 11 a.m., sometimes a little sooner, sometimes a little later, but on average, I'd say around 11 a.m. And that includes all of the data on the dashboard, including breakthrough, is updated daily starting today.
All right. Let's see, additional questions that we have. We have a lot of questions today. People are interested in what you guys are talking about. On the question about percent positivity, Ben, when we're looking at percent positivity, and you did show that it was a lot higher this year than last year, but less testing is going to be done or is being done. Can you talk about why that might be? And what less testing could possibly do to our percent positivity?
Yeah, less testing could be due to a variety of reasons. One of those would be if fewer people who are asymptomatic are getting tested. If that is the case, we would of course expect a higher positivity rate if our people who are being tested are only or are more likely to be symptomatic. But there is a variety of reasons, and we are still seeing a very high level of symptomatic in both of those groups.
All right. Other questions that we're getting. Let's see. There's so many. I'm trying to. Can you talk about what we know about long haul COVID and if that's being tracked in North Dakota? Ben, do you want to touch on if we're tracking long haul COVID, and maybe Dr. Carson could talk about what we're seeing nationally with long haul COVID?
Long haul COVID is a little bit more difficult to track than our general case numbers because by standard it is beyond the normal length of an infection. So it is very difficult to keep track of. We are doing things that we can to follow up with individuals who are infected further down the road. So we can get an idea of what long haul COVID does look like, but that is why it is not as readily available as normal case numbers.
Yeah, if I can add to that, public health follows things that have a concrete definition. There isn't a concrete definition yet for long haul COVID. This is still something very much in the works, and I would also say we don't have high quality data on just how frequent this is. We have what I sort of call middle quality data. The sort of middle quality data looks at people who've had COVID and kind of follows them up, at 3 months or 6 months or 12 months. We don't have a lot of data that compares them to an adequate control group. But what we have from that sort of middle quality data looks very troubling. So if you've been hospitalized with COVID, even a year out, so some large studies have shown up to 3/4 of people a year out are still suffering from one or more symptoms. That can be fatigue, that can be difficulty breathing, that can be the quotes brain fog or difficulty concentrating. very high rates of ongoing problems and symptoms, new diagnoses, brand new diagnoses of anxiety disorder, depression, ongoing problems with taste and smell. In outpatients with milder disease, studies have shown 25 to 50% with ongoing symptoms at 3 to 6 months out, including in young people. Now, I suspect those are probably overestimated a bit because they're not doing this, in a controlled study. But even so, those rates are very troubling. And when I hear people saying, I need to see the long-term results of vaccines, where we've now got 6-month data in, we've got full FDA licensure, and people are sort of ignoring the obvious long-term problems and complications of the virus that's sort of hitting us in the face. I have trouble understanding that, but long COVID is a real issue and a real problem.
All right. Well, we are a little past our time, and there still are a lot of questions. So we will have future town halls. I just want to let everyone know that this is definitely not the last one, and continue to ask questions about COVID. That's what we want. And for anyone that was unable to join this presentation today, it will be archived on our Facebook page, and it will also be available on our YouTube page. And so I encourage you to share it once it is available. But I want to thank all of our speakers. I hope everyone learned something today, and we will see everyone on the next town hall. Thank you.